the genetic familial breast, ovarian, pancreatic, prostate guidelines were just released today, so I wanted to provide some quick updates on this. Again, this is going to be aligned with our guest experts' expertise, but with testing for ovarian cancer susceptibility, CRIT4, there was a third bullet added: personal history at any age of non-epithelial ovarian cancer, the sex cord tumors with annual tubules, small cell carcinoma of the ovary, or I think some people call it SHOT, at any age. And then a footnote Z that acknowledges that testing for DICER1 and SMARCA4 is appropriate. Management guidelines are evolving. Consultation with expert gynecologic oncologist is recommended. Again, these are kind of rare syndromes. They're not yet in the tables, the gene tables, but there was some guidance about this because they are nowhere else in the NCCN guidelines that I'm aware of other than this specific guideline. And then again, this is again a fairly substantial change. Testing considered with a personal history of serous tubal intraepithelial carcinoma, or STIC as many of us refer to it, at any age. And again, evolving evidence suggests STIC could be associated with higher rates of BRCA1 and BRCA2 likely pathogenic variants. And then testing for pancreatic cancer susceptibility, we called out including Asner cell carcinoma, which definitely seems to be something that is associated in potentially higher risk. And then we've also called out atypical risk variants in BRCA1, BRCA2, ATM, CHEK2, etc. And the revised language, and this is across all of these genes, is risk-appropriate management should be considered. Management should be based on best estimates of cancer risk for the specific pathogenic variant in conjunction with personal and family history. So again, recognizing that, all BRCA1 mutations are not equal. There are ones that are lower risk. Same goes for CHEK2, which we've had in the guidelines for a while. And then we do know of a higher risk ATM mutation as well. And then for CHEK2, main thing here is we added the THR 476 MET variant to these guidelines as a lower risk variant. With PALB2 TP53, we've now added the prostate cancer risk and then screening starting at age 40. And then for Cowden syndrome, thyroid ultrasounds starting at age 12 used to be age 7. Then BRCA management, again, I won't go through these in detail, but there were some, I think really the way I see it is clarifications regarding clinical breast exam that should continue after risk-reducing mastectomy. Again, I think that's pretty much probably happening anyways, but now it's in the guidelines, looking at just again, clarifying the risk for primary peritoneal cancer that remains after risk-reducing salpingo-oophorectomy, and then some text specifically calling out the salpingectomy and the importance of completion oophorectomy down the road. The hormone replacement options, again, I think were clarified. There were some language that we clarified to make it more clear. Now, two other things I wanted to mention. There was a panel, because there have been a lot of changes to both the KEG and the BOP guidelines over the past year. So there was a session that I moderated at the annual NCCN guidelines meeting, and there is a paper, kind of a highlights paper that was published. And again, you can see this, we had some great speakers that commented on the prostate cancer updates, endometrial cancer updates, gastric cancer, as well as the genetic counseling perspectives. The link is available that we can send out. And the session, I was surprised, is also available for listening to in case anyone is interested. And it's free. It's, I think, available up until March.